So welcome to the Washoe County FEMA program introductory launching webinar. We're very excited to be here. My name is Rebecca Gonzalez. I'm a public health nurse at the health department. This has been a program that's many, many years in the making for our state. There's over 200 programs in 40 states, but this will be the first in Nevada. So we're very excited to be the pioneers in our state of this, and we want to put the right feet forward and get this moving in the right direction. We're also very excited to have the support of the community for this program and the support of people who've had experience with it in the past. Dr. Oki and Dr. Slotnick have been members in other states, so they have some experience with that, with FEMA. So some lessons learned and some things that we can build upon. So infant mortality is one of the strongest indicators of a community's health and well-being on many levels. In 2012, Washoe County Health District convened a strategic planning session for maternal child health focus with the help of the National Association of City and County Health Officials staff. They facilitated this meeting, and we met with stakeholders in the community to help identify the health needs in Washoe County and how we could Washoe County Health District could incorporate those needs into a strategic plan. The overarching concern was accessing and using data more effectively to improve the health of our community. FEMA had been talked about, it's come up over the years, as many of you know, and it fit this perfectly. So we were able to get that final push, and through lots of work from lots of people, here we are today. Okay. Oh, sorry, bear with me. Okay. So this webinar is hosted by the March of Dimes and the Washoe County Health District, and Perinatal Associates are providing the space for our meeting today. So FEMA is overseen by, the resources for FEMA are provided by the National Fetal and Infant Mortality Review. This group is a collaborative effort between the American College of Obstetricians and Gynecologists and the Federal Maternal and Child Health Bureau, the Health Resources and Services Administration. So what we're here to talk about today is our local program. And the agenda, we're going to talk about what FEMA is, why we need FEMA in Washoe County, the overall process of FEMA, what the case review team is, what the community action team is and their role, where we are now as a local program, and how you can participate in the program with us. So the overall goals of FEMA are to enhance delivery systems and resources, to enhance the health and well-being of women, infants, and families by improving those resources and service delivery systems, to understand how a wide array of social, economic, health, educational, environmental, and safety issues, for pretty much every issue, relates to fetal and infant loss on a local level, and to use this information to improve our community resources and systems of care to, in turn, overall reduce the fetal and infant mortality rates that we see. Examples of issues that some of the other FEMA programs across the country have been able to address have been things like access to care. California has actually switched from, they had so much data from their FEMA programs that now they're doing Black infant health, because through their FEMA programs they identified some very big disparities in that population and in the rates of fetal and infant mortality. Things like substance abuse, tobacco use, you name it, it's really individual to the community. So why FEMA? Why are we talking about it here? We seem like we're doing all right. Actually, Washoe County's infant mortality rate is among the highest in our state and even above the national average. So it's something that we need to look at. If you look, this is a range from 2010 to 2012. Some years have been better than others, but on average, our rate is 6.0 at this point, as compared to the national average of 5.1. Nevada is 5.3, so a little above the national average. Clark County falls a little below the state at 5.2, and then we're sitting at 6.0 at this point. So FEMA may help with access to data and defining root cause and why we're seeing these higher rates. And in the past, in Nevada, we've also seen significant racial and ethnic disparities. We just don't have those hard numbers, any recent numbers on that, so we didn't want to use really old data. So we hope to gain that from this as well. So more about FEMR. So fetal infant mortality is often an overlooked public health problem, although nationally the rates are similar to the infant mortality. And infant mortality is viewed as a sentinel event that serves as a measure of the community's general health status. So really, with those being hand in hand, we look at infant mortality, but fetal mortality is really hard. It's a lot harder to get data with fetal mortality. So in our program, we'll be looking at cases of fetal death with a fetus greater than 20 weeks of gestation, neonatal deaths of birth to 28 days, so many of those may be congenital anomalies or various other natural causes, and post-neonatal death 29 days to 1 year. And we'll talk more about that a little bit more refined later on as we talk about child death review and how we cross over a little bit. So the FEMR process, for all you who are visual, I really like how this shows the steps of the process. So once a death occurs, grief and bereavement support is offered to the families, and we also would receive information that the death occurred. At that point, the Washoe County FEMA program would start data abstraction or data collection. So that's through records review, and there's only 2 people that would have access to that information until it's de-identified. We would also be contacting the mothers, or in some cases the hospital may contact the mom to let them know that we would like to talk to them and do an interview and initiate it in that way. So we're still working out how that will look for us, but the key to the FEMR process is talking to these families. These families need a voice. It's often just brushed under the rug, or nobody knows what to say to them. So this is just to get the family's perspective on their care and what's gone on with their pregnancy, and maybe to find out more details about things that might be a trend that we see, whether it's infections or various other aspects of a pregnant woman. So once that records review is complete, we have a database that de-identifies, that takes that de-identified information and summarizes it for a case review team. Now, before that, as that process occurs, there may be questions that we have in which we may ask some of the physicians on our team to help us understand what does this mean in the record, and so we don't misinterpret. So we definitely will be doing that. So that de-identified case summary goes to the case review team, who then makes recommendations after reviewing a few cases. Once they see some trends happening, they then make recommendations to the community action team, which is, we're going to talk more in detail about that team, but that's the team that's going to be implementing the changes and making the policy changes. And overall, again, improving maternal and infant health. That's many of our passions who are here. So just to refine it a little more, the referrals, we would be receiving referrals from hospitals, vital statistics, and sometimes maybe a private physician would send us that referral as well. So it's kind of a backup plans like vital statistics, the hospitals. And then again, like I said, data extraction or abstraction team reviews all the records. The home interviewer will contact the parents, conduct the interview with their consent. And even if the parents decline that home interview, while it's very valuable, we will still continue to do the records review for that case. So just to put it in writing for you, everything I just went over, the de-identified information goes into our database. The cases may be reviewed with medical experts, and that was a suggestion from past experience in other FEMA programs. And it totally makes sense, because there are things already looking through the data abstraction forms that we do have questions about. And then again, the cases are summarized, presented to the case review team, and then on to the community action team. So these teams I'm talking about, what are they? So the case review team, this is going to be a long list, but we're planning on, initially anyways, this first year is kind of a learning year, but we're planning to meet every 2 to 3 months. So hopefully not to burden those members with the time constraint. Our first meeting we're hoping to have in late September, and it will be really focused at first on orientation and training. The second meeting we'll talk about ground rules and start reviewing cases. And on average, FEMRs it takes about 2 hours to review the 3 to 5 cases. This is a meeting that's closed to the public. It is confidential, even though it's the identified information. We don't want, we need to be able to look at it as professionals and make those recommendations on that level. Each member will sign a confidentiality pledge at each meeting, and we'll also be receiving those de-identified summaries to review 3 to 5 days prior to the meeting. So that's kind of in a nutshell. We'll talk more as people, as we meet with that team. The community action team, again, this is the team that's going to be making the changes. And it may not always, we may be working with other teams within the community. It's not going to be working in isolation all the time, because there's some things that we may identify that other groups have also identified. So our first meeting, we're looking at 3 to 4 months after the first CRT meets, because we need the time to have enough cases to have those recommendations. And that we're aiming for January of 2015. The coordinator, the FEMR coordinator of our program, will give brief updates to the community action team based on CRT recommendations. So just kind of where we're at as a CRT, where we're going. And then the team will move on with planning and policy development. The members in this team may be quite a bit different than the CRT, and they may also cross over. These are the members who have the political will, resources to help change, maybe experience in creating change, and passion, of course. And members will have a community perspective on how to make that change, which is why everyone is here today. So as I mentioned before, there will be some coordination with the Child Death Review Board. There will be, because Child Death Review Board does look at cases of infants 1 year up to starting at 0 to 18 years old. So those infants 0 to 1, there may be some that cross over, but we would discuss that before both reviewing that case. So Child Death Review Board members may also be involved in the CRT and or in their CAT. So this is just a visual of how the teams work. So if there's a case that seems like it could cross over, the coordinators of each team might meet to discuss which would be more appropriate, or maybe even individually go through the reviews, because our focuses are slightly different, and we do in the FEMR, we're looking at that maternal interview as well. So we're still working out the details of that. So we'll go through the separate processes, and sometimes we're going to have similar recommendations from what we're seeing in the FEMR realm of the fetal and infant death and the child death review. We may see some similar things, some education that needs to happen with both groups, or something that is already being worked on, and we're not going to be duplicating that, but we're enhancing and seeing what we can do to help as a community action team. Hope that makes sense. So it's important to note the things that FEMR does not do. So FEMA does not manage cases. We don't review those infant abuse and neglect, which the child death review would look at those cases. We don't review cases in litigation, and it is not a process to assign blame to any provider or institution for any area of the care. We're looking at an overall system change. So our timeline is very ambitious. Some things have taken longer than planned. We're pretty much around month 5 as far as the things that we've accomplished. So we've been able to secure, and I'm going to go in the next slide, it's going to tell you all the specifics about what we've been doing. But if you look at this, we're pretty much going down month 5. So right now we're at educating and recruiting the community action team, case review team members, editing our data collection forms. These are things that are going on right now. But we have produced a brochure about FEMR. We've produced our information for stakeholders and our policies, internal policies and procedures, and many meetings with many community members. So like I said, more detail. So our program received a letter from the state of Nevada granting the authority to act on behalf of the state to implement this project, to be this pilot project, with the vision that it will roll out to more of a statewide project in the future. The Nevada Administrative Code allows us to review these records as a designee of the state health officer. And we just got funded through the state of Nevada NCH block grant effective July 1st, so we are starting to really move forward and get cases. As I said, the policy and procedure manual has been developed, and we've had lots of meetings with hospitals, with many different community organizations who would be involved in this process. Which leads us to the community collaboration. This is a very, very much a community project. That's how it operates. That's how it can succeed. We can make it succeed together. As I said, the referrals are from Vital Statistics. We've talked to Renown and St. Mary's and have some procedures in place. We've worked with the Placer County coordinator, met with her in Truckee, and there may be sometimes that the person is a resident here, but she may get they might move to her area and she'll send those our way as well. But she's also been our mentor. We were able to meet with her. She's had a very successful program. Yes, a smaller community, but she's been able to give us some pointers. We have local physicians, like I said, that have been helpful along the way, and March of Dimes is sponsoring this and is an active partner in this as well. Our nurses have received bereavement training and have experienced clients who have had loss, and I kind of look at this as also on a personal level. I think many of us have seen loss, whether in our profession or on our personal level, and when I started working on this program, things just kept hitting me in the face, like, you need to do this. I had 2 nieces at 19 years old, lose babies, one at 4 months old and one at full term went in to deliver, and the baby had passed. So just real big reminders out there, and I think we're seeing it in more movies. It's coming up, and I think being proactive and helping to figure out how to help these families better and how maybe prevent some of these. So grief and bereavement resources, we have great resources in our community, so we've learned about a lot of that. We also have a pamphlet, a booklet from, is that a March of Dimes one? A March of Dimes one that we can give to the families, and we have a Sesame Street one. So we have some resources in addition to what's out in the community, but we would not be replacing the bereavement that is happening. We just make sure they're connected with that. We've met and gone to a meeting with Pilsos. So now, can you, I can't remember what the
perinatal infant loss and support group of the Sierra.
Thank you. I should have written that down. I thought I caught all the acronyms, but missed that one. Yeah, so that's an infant support Perinatal Infant Loss Support Group of the Sierras. And frontline staff from hospitals are there, moms are there, so we got to talk with some of them about this program. And then again, we met with medical records staff and Joined Together Northern Nevada, who really looks a lot at the substance abuse piece and joining coalitions together as well. So we have some great partners. And the Child Death Review Board. We've also spoken with the State Child Death Review Board as well as the Washoe County Child Death Review. So things are rolling. We're on our way. So how can you participate, and why have you been asked to be a part? You can become a member of the case review team. You can become a member of the community action team. If you're interested or you have questions or suggestions that we don't cover today, you have the emails on the screen are the staff who are in the FEMA program at Washoe County, and then the phone number is for Lisa, who is the FEMA director. Yay!
Do you have an email list started for at least the people that are on the call today and other folks that are interested in this?
Yes, we have also. Yeah, we have definitely compiled. We have a working Excel sheet that has everybody's contact, and when we send out emails, we're always going to blind, because there are some personal emails on there, so you'll only see one, just your email on there, because we need to protect people's emails. But yes, we do have a list going, and quite a good list, and there's quite a few people who we've spoken with who aren't on the call because and that's why we're doing a recorded webinar, so that people can access the information later. So questions that might come up, valuable questions that you have that we might not have thought of, they can be addressed, and we can get them on board. So,
and if people are amenable to sharing their emails, it would be nice, I think, this is Lorraine again, to be able to access those individuals for specific questions. But that's just my opinion.
Okay. Wait. Yeah, we'll work out the details of that. But I definitely see the value in that as well. So we'll work on that. That's one of those, as we set this up, little things that are going to come up. So definitely taking note of that. Great, thank you. So at this time, the overview presentation part that is complete, and we wanted to really leave time for questions, and I also have a couple of very important individuals who would like to talk about their experience with FEMR and their passion about it. So I'd like to turn the time over for a few moments to Candy Hunter, who, without her pushing this forward before she retired, and she's happily retired, but she joined us today because this, again, has been her passion, and so we're so thankful for the work that she has done to move this forward, and Beth Handler, and I mean, there's numerous people that have been involved. So we wanted to give Candy the opportunity to be here and to share in our excitement of this launch of Washoe County FEMR. So Candy Hunter.
Good afternoon, everybody. I just wanted actually to give credit to a public health nurse who back in 2008 had done some research on fetal infant mortality review. Her name is Monica Riccomini, and she's an advanced practice nurse now practicing in California. But it was her motivation that inspired us to get going, and she did a great deal of research. We wrote a couple of grants. I believe Lisa Lotrix was part of that as well. Applied to the state, and then with funding challenges over the last 6 years, as you well know, the project was tabled. But I'm very, very happy to see it moving forward now, because I think it's a critical piece of data collection and analysis that we've been missing in Washoe County. And we have just an excellent panel of participants. So go forth, and I think it's going to be a wonderful, wonderful organization and evaluation project. And I'll turn it back to Rebecca. I think she has a few more folks to speak.
Yes, thank you very much, Candy. And so I have in the room here with us Dr. Slotnick, who definitely sees a lot of the fetal infant mortality and the successes, too. So we want to applaud him for that and thank him for his passion in being here, and he's going to say a few words about his experience.
Thank you very much. My name is Nathan Slotnick. I'm a medical geneticist, and Dr. Oki and I have a high-risk obstetric practice here on the renowned campus. My previous experience with FEMR when I was in Virginia for 10 or 15 years suggested that one of the most important public health measures that we can provide for the benefit of the community is to provide accurate information for fetal and neonatal and childhood deaths. In Reno and in Nevada in general, those numbers are extremely hard to come by. If we can't really come to a conclusion as to what the rates are or the numbers are, we can't even begin to get our hands around what's going on in the community that we can address. I think the most important initial goal for this group should be to try to identify accurate information and then move toward ways of looking at systemic approaches to improve the health of pregnancies and neonatal and childhood health as well. But the first step, the really big first step, is accuracy, meaningful, objective data that we just can't obtain right now. Thank you.
Thank you, Dr. Slotnick. So are there any questions at this point about our process, about what's going on with this, why we're doing this, how we're doing this? Any questions or concerns, thoughts?
I have a question, Rebecca.
Yes.
Mary Boyle. As a nurse on labor and delivery in St. Mary's, if we have a fetal demise, how is our role? Are you getting your information through medical records? Do we need to notify you?
We are working that out with each hospital because each hospital is going to be a little bit different. So there have been a couple of things. There have been a couple of proposals out there of how we could do it.
Okay.
So we'll make sure that's very clear. Like one hospital has one central person who's giving that information. So yeah, we are working with medical records, and we'll find out what's the most appropriate method of getting that. Yeah.
Good, because I hadn't heard anything, and I thought, I thought we were supposed to be doing something we hadn't heard.
No, we're kind of working out the kinks right now. So yeah, we'll definitely notify you and all involved at each hospital of how that process will work within your hospital.
And Mary, this is Candy Hunter again. I just wanted to comment on your question, which is a really good one. The state has been working with the Maternal Child Health Advisory Board in response to Dr. Sandra Koch in Carson City, who wants to create a maternal mortality review board. And there were concerns about the birth certificates, which would include the fetal death certificates and death certificates for infants. And I think the state is working on trying to get better information collected because it's not entirely accurate at this point. And in some ways, the hospital nursing staff could potentially be a source of assistance for that project as well, which ultimately gives us better data for this process.
Yeah.
Yeah, and thank you for that question and for your willingness to give us those referrals. But we will keep you posted as to how that will happen.
Great.
But yeah, we're finding it's different at each institution, so we'll definitely get that ironed out.
Thank you.
You're welcome. Thank you.
I have a question. This is Kathy from one of the nutrition.
Yes.
You said that you guys will or we will not review abuse or neglect cases. Is there a reason for that? Like maybe look back and see if there's anything you saw early on that would have given us a clue that abuse might happen?
Traditionally, FEMA programs don't look at known abuse or potential ones that are suspected abuse because there's a legal investigation going on. We don't want to get involved and compromise that investigation at all. Is part of the reason. I can get back to you on with a better answer on that, but I just know traditionally it's not. And also because we have our Child Death Review Board who are looking at least at the infants. So it is a little bit of a gray area, and there may be times, which it hasn't happened yet apparently, but there may be times when we may be at a maternal interview and have some red flags raised, and we are required to report that. That is one of the few times where we would have to make a report. But in the history of the FEMR programs across the country, everything I've read is that hasn't happened because most often those women don't consent to the interview for that reason. So it's again, it's a very gray area, and yeah, we're going to have to address that when it comes up.
What's the time frame between that?
We'd like that to be as soon as possible. So within 2 to 4 weeks is ideal. 3 months is too far. I know I've seen that. That's way too far out. But they're going to be going through the grief process and may not remember everything either at that point. So it is really important also to reach them to make sure that they're getting that grief and bereavement support that they need in that early time frame, so they know what's out there. So as they go through the process, that they would be able to access those resources. So ideally, within 2 to 4 weeks, that they would be contacted. Great questions. Any other?
Hi, Rebecca. This is May from the Washoe County Health District.
Hello, May.
Thank you for your very informative presentation. So back to your definition slide, and I didn't see that the location is part of definition. So are you looking at the all births occurred in Washoe County or just for Washoe County residents?
Yes, thank you for that. I meant to mention that. It's for Washoe County residents. So for our pilot Washoe County FEMA program, we're looking at Washoe County residents. I know Clark County is looking at rolling a FEMA program out after we get ours going at some point. So right now, focus just on Washoe County for us.
Another question, I'm kind of why you this kind of mortality rate. I'm kind of calculating back about the kind of possible volume. So like a burden, so for the infant death, look like the definition is having the 6.0. Is that the correct average per 1,000 live births? I assume.
Yes.
Is that correct?
Yes.
Okay, so every year in Washoe County, so we had like 5,000, around 5,000 births. So this looking like, we have 30 cases-ish for the infant death. How about some fetal mortality? Do you have any general estimate?
Yes, we do actually.
Okay.
Some of it is still pending. So our fetal, let's see.
Because you mentioned that like for every review it's 3 to 5 cases. I'm not sure.
Right.
So is that every quarter or every month or for the review or as needed?
Right now, we're looking at every 2 to 3 months. When FEMA programs are first getting started, there's a lot of kinks to work out and learning that has to occur and getting familiar with the papers. So it's going to take us longer to go through those. So that's why you see the 3 to 5 every 2 to 3 months. But we may have to meet more frequently depending on our numbers. But right now, we're trying to start here and go forward. The preliminary numbers that I have for Washoe County fetal mortality is 5.3 per 1,000 live births in 2013.
So probably the frequency of the meeting probably need to consider to improve because you calculate back the case volume.
Right.
So it's like every time 3 to 5 cases review or every 2 to 3 months is not sufficient.
Right. So this first year will be that way, and then we'll reevaluate, look at our numbers, and probably have to increase that the next year. Many FEMA programs meet monthly for that reason. It does vary based on your rate. So some communities may just meet quarterly because they don't have huge numbers because they're small communities. So yes, that's definitely something we'll reevaluate, but we had to find a number that would be realistic for us as we're learning and moving forward, because we want to do it right. So we know there's going to be some learning. So we're looking at, I believe it was the first year, we're looking at doing 30 in the first year of our grant as we learn, looking at 30 cases, and then the following year we'll see.
So another, do you have a time for another question?
Yes, ma'am.
Another question. So I'm looking at the analysis perspective. So because your database is de-identified, is that correct?
Correct.
Okay. So what if, say, the following, like second pregnancy or third, had the same incident or same event happen? So how do you have the way to link that back? Like for this mother, this woman had two pregnancies, but the first one had a fetal mortality. The second year or second pregnancy still had a fetal, but it happens within the one person, but the two individual events. So there's a way to link it back, or or don't consider it back.
That's a good point, and Dr. Oki's looking into, I think he has some information about this. The data abstraction form that we use, I believe, has a question about it, but we'll definitely, that's a great question, and definitely something to look at. But yeah, because it's de-identified, and they get a specific Washoe County FEMR ID number that goes in our database, and that's the only ID number that they have on our end.
Yeah, so this is kind of like event-based or the person-based, or both.
Yeah, and Dr. Slotnick just brought up a good point. The data gathering would include those previous pregnancies, so that would come up in that way. So yeah, and we're going to look at the form and probably add about previous.
Yeah, because the intervention could be targeted to the person. Part of it.
Yeah, this is Dr. Oki. I'm looking at the data extraction sheet, and it does not have the past obstetrical history in that, so we can modify it. That's probably a fairly easy thing for us to do.
Yeah. Or in the database, you can create identifier based on the previous report.
Right, yeah.
It's kind of, there's some common link there, so in order for you to link to the previous.
As a geneticist, many of the fetal and neonatal deaths will have a genetically identifiable cause. I think it'll be crucial to identify those patients and try to figure out a way of whether the system failed the early prenatal diagnostic system to allow those patients to have as much information as possible. So previous pregnancy history will be a crucial part of the data gathering that we will initiate.
Yep. So definitely we'll look into adding that. I know we can adapt the forms to our needs in our community and the things that we see or that maybe people haven't thought of before. So yeah, we'll definitely work on that. Thank you, Ray. Anyone else have any questions? I'm sure as you think about it, if you want more general information about FEMR, go to FIMR.org. www.nfemr.org has some very valuable resources on there. They also have physician FAQs. There's a HIPAA document about how and why we're able to get the records outside of or within the bounds of HIPAA. There's things that other programs have done. There's a whole bunch of information on there. And if you need help getting on there or need anything, we are here as that support as well to connect. We also get support from them. I have actually an email out to them they offer technical support and help us with especially this first year and moving forward. Any other questions? Anyone else in the room have anything? Well, I really appreciate everyone's participation on our first ever Washoe County FEMA webinar and on launching this project. This is a huge step for us. It's been, like I said, many years in the making. And I do apologize for some of our technical, we're learning about the GoToMeeting webinars. So I hope that people were able to see and hear most of our discussion today. And we will be archiving the webinar, and it's been recorded today, and we'll archive that so that others, like I said, can come back to it and learn about the program. Where do you place that archive? We're going to send that out to you. We were just talking about that. Yeah, we'll send that out. I believe it'll be on the Health Department site and probably the March of Dimes as well. I know Michelle Naborolo, she was going to be on the call today, but had another obligation come up. So she will, I believe, is planning to place it on the March of Dimes website as well. So we will get that information out to the group, to everybody who participated today, and who's in our email list as well, and anyone who is interested in participating. So with that, I don't want to take up any more of your lunch time.
Thank you very much.
And I appreciate.
Thank you.
Thank you.
Thank you.
Thank you.
Great job.
All right. Bye-bye.